Welcome back to our next panel. We have three fantastic speakers today here with us for the next series of lectures. Next, we're going to hear from Dr. Rob Bristow on bowel complications in GYN cancers, perforations and peritonitis. He may have come up with an alternate title, but that's what I'm going with for now. I've actually asked Dr. Bristow to be a presenter at this talk for, I think, probably 11 years in a row. So not to be deterred, he finally said yes, for which I'm extremely grateful. Dr. Bristow is really, a true leader in our field. I mean, he's had multiple leadership roles, but he's also well known as one of the most exquisite surgeons, gynecologic cancer surgeons internationally. He's the chair of OBGYN at UC Irving, and he's going to be speaking to us right now. So Dr. Bristow, welcome. I will introduce Dr. Mash and Dr. Alanese after this.
Cool. Thanks, Joni. Can you guys hear me okay?
We can.
Okay, perfect. I'm just going to go back to the beginning, but I do want to thank you for the opportunity to present. It's really a great honor. I'm sorry I haven't been able to get up there personally as of yet. I don't have any financial disclosures to make. I do have a couple of actual disclosures, though. One is I've been doing this for about 25 years and have had just about every possible complication you can have with respect to the bowel and GYN cancer and GYN surgery. And being that this is a survivor's course, I wanted to provide a little bit more expansive coverage than just focusing on bowel perforation and peritonitis, because we don't see those things extremely commonly. And so I took a little bit of executive liberty and expanded the scope of what we'll talk about. And then finally, I just want to express my appreciation to all the organizers for the conference, but especially the GYN cancer survivors and their families that are taking part in this webinar. You guys are our daily inspiration and the reason that we do what we do. So just to give a general overview. Oh, I'm sorry. And fourth disclosure, we have 3 rescue dogs here in the house, so there could be chaos breaking out at any moment with barking dogs, but we'll push ahead. What I wanted to do was just give a general overview of what I'd like to cover in the next 20 odd minutes or so. We'll do a brief overview of the GI tract anatomy, talk a little bit about common terminology, review some of the common causes really of bowel complications, which are mostly related to either the GYN cancers themselves or the treatment that we prescribe for those GYN cancers. And then talk about really 4 main categories of bowel complications: the paralytic ileus, bowel obstructions, intestinal injuries or anastomotic leak with perforations, and then finally finish up with fistula, bowel fistula. So just to level set everything, so we have a common terminology. Essentially, the bowel is the entirety of the gastrointestinal tract, everything from the stomach to the rectum. When I say gastro, it means stomach. Entero, that means small intestine, and colo is colon. When we talk about decompression, basically we're saying we're trying to describe relieving a buildup of bowel contents that's become blocked. A diversion is to basically create an off-ramp for the buildup of those intestinal contents so that they're not building up and backing up any longer. An anastomosis is when we've removed a portion of the intestinal tract and then we hook those 2 ends together. An ostomy or a stoma is when we bring up a segment of the bowel to the abdominal wall so that it can empty externally outside of the body. And then finally, a fistula is some kind of a pathologic connection from either one organ to another or from an organ to the body surface. So this is just the basic intestinal tract anatomy. It starts at the esophagus, goes through to the stomach. You can see my pointer here. The stomach empties into the small intestine, which is comprised of the duodenum, the jejunum, and then the lower part is the ileum. The small intestine empties into the colon, which starts at the cecum, goes through the right colon, the transverse colon, down the left colon into the sigmoid colon, which is shaped like a sigma, and that's why it's called that. And that empties into the rectum and the anus. So that's just a basic overview of the GI tract anatomy. Common causes of bowel complications from GYN cancer include, as I mentioned earlier, the treatment that we use to treat the cancers, and that surgery can be minimally invasive with either laparoscopy or robotic surgery, or open or laparotomy surgery. And the surgery can precipitate a paralytic ileus after an anesthetic. They can all result in some sort of an injury to the intestinal tract, either by a direct cutting injury or a thermal injury from the electrosurgical instruments that we use. It can result in an anastomotic leak, or where we put the bowel back together, that hookup starts leaking. Surgery can result in a bowel obstruction or fistula. Radiation therapy, on the other hand, is typically associated with either bowel obstruction, a blockage from scarification of the intestines or a stricture of the intestines that were in the radiation treatment field, or a fistula because of damage to the normal tissues surrounding the tumor that's being treated. And then the various types of gynecologic cancer can all result in various combinations of obstruction, leaking, fistula, depending on their anatomic location and what their typical patterns of spread would be. So we'll start with just talking about the adynamic ileus. This is also known as a paralytic or functional ileus. And what that means is the bowel normally has a peristaltic motion that pushes the intestinal contents from top to bottom. And an ileus is when there's a non-mechanical stoppage or slowing of the flow of the intestinal contents. And it's commonly seen after surgery as a result of the anesthetic or significant manipulation of the intestines during the surgery, or as a result of medications like opioids, or can also be seen with generalized inflammation, as in the case of a peritonitis or a bladder injury. The symptoms usually include nausea and vomiting. There'll be distension of the abdomen, and usually there'll be absence of passing gas or flatus. When these are simple cases of adynamic ileus, they'll usually resolve spontaneously in 2 to 5 days. If it's considered a paralytic ileus, that may last 7 days or longer. And it's normal for the intestine to take some time to recover after surgical treatment. And interestingly, the small intestine normally recovers the quickest, usually within 24 hours, followed by the stomach. And then lastly, the colon, which can take up to 72 hours to recover normal function, even in normal circumstances. So the treatment for an adynamic ileus is usually time. Most of these cases will resolve on their own, just given enough time for the body to re-equilibrate. Sometimes a decompression is required, and that it's usually a nasogastric tube, where a flexible tube is placed through the nose, down the oropharynx, and to the esophagus and into the stomach to evacuate the stomach contents so they don't build up and the patient doesn't have to undergo vomiting to relieve the pressure. This also prevents the normal fluid that's produced in the intestine from having to go down into the small intestine and allows the bowel to rest, we say. It's not comfortable. We don't like recommending it for patients, but it is a helpful intervention that we can do to try and relieve the suffering related to an ileus. There are some medications that we can give. Some are prokinetic or help the bowel to resume that peristaltic function. Others will block the paralytic effects of opioids. But in most cases, we support patients with intravenous fluids, or if the time extends for a long period, that could be nutritional support in the form of parenteral nutrition. Ogilvie syndrome is a unique type of a paralytic ileus. It's typically is seen in elderly patients in the 7th and 8th decades of life. It's also called colonic pseudoobstruction and can actually mimic a large bowel obstruction. As I said, typically it will occur in older patients after surgery, especially if that surgery has included significant manipulation of the intestines, and or if there is a high volume of narcotic medication on board after that surgery. It's unusual because it presents with a very dilated right colon, but air in the rectum. Most of the time it will resolve spontaneously, but there can be significant adverse effects, including prevention of full respiratory function, compromising the blood supply to the bowel or bowel ischemia, which can ultimately potentially result in a perforation. So in most cases, we'll try and manage these scenarios just with time and decompression. But if the intestine seems like it's dramatically dilated, or there's a concern for bowel ischemia or perforation, semi-emergent or emergent surgery may be required. Now, bowel obstruction is different from a paralytic ileus in that there's a physical blockage to the passage of the intestinal contents somewhere along that continuum from the stomach down to the rectum. And it may be either partial or complete, can involve the small bowel, the colon, or both. Common causes include GYN cancers, which can cause this either by having a large mass that's sitting either in the pelvis or on the intestine that has a focal site of blockage, or we can see this with what we call peritoneal carcinomatosis, where we have multiple small, tiny tumor implants throughout the intestine. It almost looks like somebody's taken a couple of handfuls of grains of rice and scattered them onto the intestinal surface, which impairs the ability of the intestines to move. Adhesions or scar tissue after surgery or radiation can also cause a bowel obstruction, and rarely, but not never, we will see sometimes after surgery a patient will develop a hernia and a loop of intestine will herniate through that opening, and that will result in a bowel obstruction. The symptoms are not that dissimilar from a paralytic ileus. Patients will usually complain of having a distended abdomen, abdominal pain, the absence of passing of gas or flatus, and have nausea and vomiting. The consequences can be fairly significant. This progresses for a prolonged period of time. Patients may be subject to malnutrition, and if the obstruction is not relieved and the dilation of the bowel progresses, it can lead to a perforation of the intestine, which can cause peritonitis, which is an inflammatory condition of the abdominal cavity and usually an emergency, or some sort of a fistula communication with other structures or to the skin. Now, we usually will diagnose a bowel obstruction based on clinical symptoms. An abdominal X-ray will typically show this kind of a finding where we see multiple loops of dilated intestines that are, appear to be sort of going in a stair-step pattern up the abdominal wall, or we'll see a CT scan. We can see the same findings with multiple very dilated loops of intestines that are filled with fluid. And these are hallmark findings for an acute bowel obstruction. So X-ray and CT scan are the way that we most commonly diagnose this condition. Treatment will depend on the cause and the acuity of the situation. So in most instances, we'll try and manage these situations conservatively by decompressing the intestines with a nasogastric tube and providing nutritional support with TPN or total parenteral nutrition. In some cases, it may require a delayed surgery to try and go in and correct the obstruction. And that might be a resection of the diseased segment of intestine and a rehookup or anastomosis, or a diversion might be recommended. In other words, bringing the proximal flow of intestinal contents out to the abdominal wall. Now, sometimes the bowel obstruction can create emergency situations, and that is if it's what we call a high-grade or complete obstruction, or there has been a bowel perforation. Those are surgical emergencies. They can occur either in the small intestine or the colon, and require some sort of urgent procedure or operation to relieve the obstruction and divert that flow of intestinal contents. Depending on where the obstruction has occurred, the diversion or procedure will occur above that level of obstruction. And that could be an ostomy in the small intestine called an ileostomy. It could be a bypass operation, or it might be a colostomy. Now, just to give you some examples of what this looks like, surgical resection and anastomosis or a rehookup would be for an isolated sort of tumor involved in the intestine, where we can successfully resect that and see what that would look like in real life here. Successfully resect that involved segment of intestine and then rehook the two ends back together. And that can be either in the small intestine or in the colon and the large intestine. It doesn't really matter, but the criteria that we use to select patients for this is that the patient needs to be clinically stable and the tissues need to be of healthy condition, so that when we put the two ends of the intestine back together, we have a high degree of confidence that those tissues will actually heal. Now, in some circumstances, we need to do a bypass surgery. And these are cases when there's either a blockage from a tumor mass or radiation damage, but the patient is not stable enough to undergo a more prolonged operation for resection and anastomosis, or the tissue conditions are so unhealthy that if we were to do an anastomosis and put things back together, we would not have a high level of confidence that things would heal successfully. And in these circumstances, really the goal is simply to relieve the obstruction, because doing a full resection would carry unacceptable risk. And these are just a couple of cartoons as to what those procedures can look like. On the left here, you'll see an obstructing tumor that is what we call in a hostile pelvis, meaning not amenable to resection. And so we would connect the small intestine to the colon and allow the path of intestinal contents to bypass this trouble spot down in the pelvis. We see the same thing, not uncommonly related to radiation damage to the small intestine from cervical cancer treatment or uterine cancer treatment, in which case the bowel becomes blocked because of damaged intestines, and we have to do a bypass of that area by connecting the small intestines directly to the colon. So intestinal diversion, I mentioned earlier, basically that is an off-ramp for the flow of intestinal contents, and what type of diversion is recommended or constructed really depends on the site of obstruction and how you can, where you will select a site of intestine above or proximal to that obstruction to successfully create an off-ramp. Now this also, these procedures also apply to patients who would have fistula, and we'll talk about fistula in a few slides. But a diversion can be at the stomach level, which is called a gastrostomy tube. You can see a picture of what that looks like here, where a tube is placed directly into the stomach and brought out onto the abdominal wall to allow the intestinal contents and stomach contents to evacuate before they have to go downstream to an obstructed small intestine. If the obstruction is in the colon, we would do what's called an ileostomy and bring up a stoma proximal or above the level of the obstructed colon to allow the off-ramp to occur before the contents get to the blockage in the colon, or a colostomy, which can be almost anywhere in the colon as long as it's above the level of the blockage. Now, all of these stoma applications will require some sort of appliance to be placed on the abdominal wall to collect the intestinal contents. The goal with diversions is to relieve the obstruction or divert above the level of the fistula. And we typically do these when an anastomosis would carry an unacceptable risk because of unhealthy tissue or patient condition. Another option that we have to relieve a large bowel obstruction is the placement of a colonic stent. And these are expansile, typically wire cylinders that can be placed into the colon, into the area of the obstruction, and then expanded to keep the colon open so that there's not a blockage. And we would usually recommend trying this approach in instances in which the cause of the obstruction is not surgically resectable in order to relieve the blockage. And the stent placements can be quite successful, and they can actually bring long-term relief to up to 50% of patients that undergo this procedure. So this is a good potential option to have in your toolbox. I wanted to say a few words about a very difficult condition that our patients face, and that's a carcinomatous ileus. And this is a functional mechanical blockage of the small or the large bowel, but often doesn't have a focal point of actual obstruction. And it's because of that miliary or grain of rice type involvement of the intestines by usually a disseminated cancer like ovarian cancer, typically in the recurrent setting, that prevents the normal peristaltic movement of the bowel. Sometimes this will improve spontaneously with decompression and resting the bowel, but usually it's not a surgically correctable problem if it involves an extensive portion of the small or large intestine. I put here without significant risks because in some cases it is surgically correctable, but will require removal of so much of the intestinal tract that the person may potentially be dependent on intravenous feeding or TPN for the remainder of their life. And so that is a decision that needs to be carefully calculated. In the absence of a surgical option, we normally manage this with a decompression and IV fluids, nutritional support with parenteral nutrition, but ultimately relieving the blockage that's due to peritoneal carcinomatosis or carcinomatous ileus requires effective systemic therapy. And then if there is a successful response to treatment, we can always reconsider surgery later that might be more limited than what we would have to do on the time of initial presentation. So this is just a cartoon showing one of the reasons that carcinomatous ileus occurs with peritoneal carcinomatosis is when we have a primary ovarian cancer. Those cells exfoliate into the abdominal cavity and can be distributed around the abdominal cavity in the normal peritoneal fluid that we all have in our abdomens. And those individual cells can implant on the surfaces of the intestines and eventually congeal into a situation in which the intestines are essentially encapsulated by a very thin film of cancer deposits that prevents that normal peristaltic motion. So we'll say a few words about intestinal injury and an anastomotic leak here. And these are generally surgically induced injuries to some portion of the intestine that occur as a result of either debulking surgery for ovarian cancer or a minimally invasive hysterectomy for endometrial cancer. There is a higher risk if there's previous scar tissue and adhesions from either previous surgery or something like intraperitoneal chemotherapy or intraperitoneal dialysis, but anything that increases the scar tissue and adhesions in the abdominal cavity increases the complexity of the cancer surgery and puts the patient at higher risk for intestinal injury. If these things are recognized in a timely fashion, meaning at the time of the initial surgery, that will often facilitate a simple repair and there will be no consequences. If the injury is not recognized at the time of the initial surgery, there can be greater risk of complications and there can be leakage of bowel contents into the abdominal cavity, which can cause inflammation or peritonitis, and the patient will become quite sick. An anastomotic leak or a leakage of the hookup after we've intentionally resected the intestine and put it back together can occur in 3 to 7% of cases after a bowel resection. And we know that patients that have poor tissue quality as either a result of malnutrition or prior radiation therapy are at higher risk for having a leak from an anastomosis. And in some cases, we actually recommend what we call a protective diversion or an ileostomy or colostomy above the level of the anastomosis, so that if it does break down or leak, the consequences will not be so severe. And most of these cases of anastomotic leakage, patients will present with intestinal contents either leaking intra-abdominally, which causes that inflammation and peritonitis, out through the surgical incision, which results in a cutaneous fistula, or out through the top of the vagina after hysterectomy, which results in a vaginal fistula. And in most cases, these will require some sort of a diversion to to collect the intestinal contents and a revision of that anastomosis to correct the leakage. In rare cases, they will heal spontaneously. I wanted to also mention a few words just about fistula, because these are not uncommon in gynecologic cancer practice. And a fistula is a pathologic connection between two organs or from an organ to the body surface. They can be cancer related, which is usually a result of direct tumor invasion between organs. And it's most commonly seen in patients with cervical cancer. Because of the proximity of the cervix to both the bladder and the rectum, fistula communications to the rectum and the bladder are quite common. And sometimes we will only see a fistula manifest after the primary tumor has been successfully treated, because as the tumor regresses out of its communication with the rectum or the bladder, the contents of the intestine or the bladder will then travel through that pathway that the tumor was previously occupying into the cervix or the vagina, and thus create a fistula. So fistula can also be surgery related and oftentimes associated with very complicated procedures that require a lot of dissection for scar tissue. They're associated with bowel anastomoses and sometimes can be due to a thermal injury from electrosurgical instruments that we use in minimally invasive and open surgery. They generally present after surgery as either peritonitis or leakage of intestinal contents out through an incision or through the top of the vagina. They can also be related to radiation, because those organs that I mentioned earlier, the rectum and the bladder, are in very close proximity to the main tumor, and they will get damaged as a result of the radiation, and the effects of the radiation prevent effective healing of those normal tissues. So for an example, an enterocutaneous fistula is where a portion of the small intestine starts communicating with an incision on the abdomen, and those small intestinal contents will leak out and have to be collected. This can be due to extensive surgery or an anastomotic leak, or as a result of a thermal injury during surgery that was not appreciated at the time of the surgery. And the intestinal contents will seek the path of least resistance. They'll initially go into the abdominal cavity, but they will try and get out of the body. And that is usually through one of the incisions in the abdominal wall. And as I mentioned, until the contents find that path of least resistance out of the body, the presentation can be preceded by leakage into the abdomen and peritonitis. The treatment of fistula in general includes stabilization of the patient and figuring out some way to collect that drainage. And in some cases, we'll place a wound vac on the incision to collect that drainage, but to try and keep it from becoming disseminated throughout the abdomen and impairing the wound healing elsewhere in the incision and the body. If a fistula is detected very early, it may actually be amenable to immediate repair. But you really have to detect these things within the first 6 to 12 hours of their presentation to have a high likelihood of successfully repairing it. In general, we treat any infection that's present and drain any abscess and recommend some sort of a diversion procedure or bypass to allow the tissues in the body a chance to heal. If the tissue hasn't been extensively treated with radiation, we can sometimes do expectant observation and support patients with intravenous fluids and nutritional support, and have a reasonable expectation that there may be a spontaneous closure. If that doesn't happen, then usually a second surgery is recommended to go in and resect the damaged tissue and repair the fistula. However, this sort of definitive surgical treatment may need to be delayed if there is still active cancer present, because we don't want to do a fistula repair while we're still actively treating a cancer with either radiation or chemotherapy. So the timing needs to be really well coordinated. So just to summarize, gynecologic cancers arise in close proximity to the GI or tract or bowel and are not infrequently implicated in causing bowel complications. They can result from both the cancer and the cancer treatment. Surgery, radiation, and the cancers themselves can cause paralytic ileus, bowel obstruction, intestinal injury, and anastomotic leak, as well as fistula. And management is usually determined by the specific cause, the patient's condition and their acuity and their cancer status. And as I say all the time, in most cases, these sorts of complicated scenarios are best managed by an experienced gynecologic cancer team, which includes not just GYN oncologists, but nurses, surgical oncologists, intensivists, stoma therapists, psychiatrists, the whole team. So with that, I will finish and exactly on time. Thank you very much.
Really phenomenal, Dr. Bristow. Thank you so much. Really, really appreciate your presentation and your words of wisdom. If you have questions about this talk as we go along, please type them in the questions, the Q&A section in your Zoom. And we are going to have our discussant, Dr. Alanis, come on after the next talk, and questions on both talks will be addressed live with our panelists. So thank you so much. That was fantastic, and I really, really appreciate it.